How's everyone feeling? I'm in that coveted spot after lunch and before cocktail hour. So I don't know what it says about me that I could quasi-produce a film and that was not the direction I went. So I'm actually having more fun doing this than anything I've done up to this point in my career. But I think it'd be good if we started with a really simple question. Who hit the tables last night? Who gambled last night? Stand up. Stand up. Only take a second, I promise. No one's going to be personally embarrassed, just group embarrassment. All right. All right, so look around. Half the room, thereabouts, something like that, maybe a little less. If you lost, sit down. And that includes me, so I'll sit down too. All right, this is instructive. Look at who's left. And you can, those of you that won, we're going to find you after the happy hour ends, but you can sit down as well. So why do you think that is? Because the odds are stacked against you, right? And why do you think casinos have these awesome buildings, right? Because they know that. So it's not that different in the delivery system, right? About 3/4 of the folks who played, right, or who got care, lost. And that's about the same thing we see in the data when you look at who goes where in the hospital system. About 3/4, 2/3 are going to the very expensive locations of care for no additional value. Why do you think hospitals are building large buildings every time you turn around? There are some similarities there. All right. So the specific issue that I want to talk about is the variability in price and quality inside the delivery system, inside any network. Doesn't matter which of the BUCA, rental network, et cetera. We see 3 to 10x price variability across all networks. Now those are just numbers. So in terms of where we came from and why we started, our founder, Dr. Jeff Rice, back in 2005, his son needed a medical procedure, maybe a 1.5-hour outpatient procedure on his foot. Simple. So they found the best pediatric orthopedic surgeon they could, and they went out, saw him, understood what the case was going to be, how it was going to work, and said, you know, where are you going to do the case? And he described it. So Dr. Rice called the hospital and said, what's it going to cost? Any guess what they said? We don't know, and why are you asking? Why are you asking? Can you imagine buying a car and someone saying, we don't know, and why are you asking? Makes no sense. So he said, well, I'm asking because I'm on a high deductible plan. I'm paying a good chunk of the bill. I want to know if you want to get paid. I said, all right, we'll call you back. A day goes by. They call back and say, you know, we forgot to take into account your network discount. It's probably going to be more like $15,000 to $25,000. 15 to 25. So their first response to him was $35,000 for a 1-hour outpatient procedure. They called back with a network discount, $15,000 to $25,000. They thought that was good news. He said, thanks very much. Went back to the physician, the surgeon, and said, do you operate anywhere else? He said, oh, yeah, I operate right downstairs in this building on Tuesdays and Thursdays. I thought you wanted Wednesdays, but it's actually a great location, more convenient, drive-up parking, lower risk of infection because we're only doing those cases there. Great location. So Dr. Rice called downstairs to the non-hospital-owned surgery center in this building, and in one phone call, 1 minute, got an answer. What do you think they told him the price was going to be? Same procedure, same physician. I hear 10,000. Do I have higher or lower? 4,000. $1,500, right? So 25,000 or 35,000 if you didn't think to ask about the network discount, down to $1,500 for the same procedure, same surgeon doing the case. And the point is not that happened to us, but it is why we started the company. It's because that's what's happening to your employees all day, every day in the delivery system. They don't know what questions to ask, right? But there's another problem that's just as bad as the cost and quality issue. Anyone guess what the average attention span of a goldfish is? You know, the one you've got sitting on your counter if you have kids, very likely. Take a guess. No, it's actually less than a second was the guess. They're actually 9 seconds. Now, here's the humbling part. What do you think the average attention span is of me, you, Americans in general? Any guess? 8 seconds, yeah. So don't ever forget when you're thinking about all this really cool stuff you figured out in healthcare that you got about 8 seconds for someone to give you the time of day on it. That includes your employees, that includes your clients, that includes everyone you're trying to change the world for. So why us? Well, we've been around since 2007. We are independent, privately held, profitable, so we don't answer to anyone else except the folks that are ultimately paying the bill, the employers and the employees. We typically work, or we often work direct to employers, and the beauty of the partnership we now have with Cypress is normally we don't work under 1,000 employee lives. But because of the TPA partnership, we can work with any and all of Cypress's employer groups. So large and small, all across the country in all 50 states. So you're going to see this green, yellow, red theme repeat when we get into some of the demo and the screenshots. And again, it's simple on purpose. So this is the primary interface of how we help people understand where to find value in healthcare. So this is going to be an easy one. Raise your hand if you don't know what to do when you come to a stoplight. I feel much safer now, right? Everyone's good. But think back to that 8-second rule, right? It's got to be this simple. So we translate all of that arcane, convoluted healthcare information into green, yellow, red, something that's familiar to most folks. And in terms of the approach, we kind of hold true to these 3 design principles. It's got to be practical, it's got to be simple, and it's got to be integrated. So we'll go into the detail behind each of them, but practical just meaning that not all opportunities to save are created equally. Right? You're not going to save much money shopping your doctor for physician visits, office services, 10% here, $10 here, $5 here, minimal. Where that physician sends you for downstream care, tests, procedures, imaging, et cetera, thousands of dollars difference. So focus on what moves the needle. Simple we talked about. Our litmus has always been, in a minute or so, can someone get into the tool and out with the question they're looking for answered? If they can, they'll use it and they'll tell others about it. But you might only have 8 seconds for them to make a face value judgment of whether they can do it or not. And integrated is particularly critical for our TPA partnership with Cypress. So in addition to the claims integration, eligibility information, anyone they work with that you work with, we're more than happy to partner with, and we're already partnered with a number of them. AHH is an example, American Health Holdings. We can do some pretty cool stuff on the pre-cert side. So when they get a pre-cert, we get notification of that for the employers that want to do this, and we check to see where that member is about to be sent. And if it's a red or yellow, high-cost, low-value provider, we call the member and let them know their options. Right? They may have never even heard of the Bluebook or used the tool, but you're catching the right people just before they get care instead of looking out of the back of the bus. Similarly with Pareto. We work with Pareto across a number of their groups as well. On-site clinics, near-site clinics will give the practitioner, the physician, the NP, the tool. So when they're seeing your employees and they need to send folks for additional care, they know where to send them. They can actually look before they write that referral. So the net of it is we see an opportunity to save up to 12% of total medical spend. Now I want to level set. Most employers don't realize that level of savings. That's for folks who are going all the way out to pretty aggressive benefit design, whether it's reference-based pricing with a twist that I'll explain later, or just significant rewards and communication programs as well. But we would expect to see low to mid single-digit savings of your total medical spend in the first year. And that's a big number. And because our fees are low, the ROI is strong, and it's very easy actually to get to it in the first year. And because we're focused on the items that really move the needle, employees are saving real money every time they do it. So I'm going to flash forward to what we're going to get into in terms of the solution itself, but keep in mind that 8-second rule. And this is kind of what it looks like in our view when you apply a stoplight to healthcare. One page, at a glance, someone sees immediately that, hey, there's a price range, and it's big, and here are some of my options. I don't have to drill down or do a lot more to understand right out of the gates that I can save significant dollars. And then support the drill downs into the physician detail and the provider detail. But we'll come back to this. So first things first, when you're trying to save money in healthcare, you got to get clear on what's driving the cost in healthcare. Right? So there's at least 2 components. There's the physician cost and the facility cost. All right, one of them is the tail, one of them is the dog. So raise your hand if you think the physician is the primary driver of healthcare costs. You guys are too good. Yeah. It's the facility. And this is what it looks like. So if we do nothing else, if everyone says, you know what, we got to wrap up right now, this is what we have to cover together. What you're looking at here is data from one of our self-insured employers. Each one of those horizontal lines is a claim, or a patient in this case, for a colonoscopy. In network, in a 12-month period, in one geography. Right? In network, one location. And this is the allowed amount, right? This is after whatever discounts are applied. So what you can see is some folks paid over $3,500, some folks paid $1,000 or less. Same procedure. We strip out any sort of complex or complicated colonoscopies that have an ER or an inpatient stay. 300% price variation for the same thing. But notice that, and this is the good news for employers and employees, in looking at this data, right, there's the green portion, which is what the physician pays, and the blue, which is what the facility was paid. So what do you notice? The green doesn't vary much, right? If you want to save money in healthcare, if you want your employees to save money in healthcare, it's not about doctor shopping, right? And that's where every other tool starts off left and stays left the whole time. They tell you to look up your doctor. But if you do that, and we've done use cases on this as an employee or a consumer, you look up your doctor and you say, gosh, you know what? Doesn't really matter. I'll go to the one that's closest. I'll go to the one whose picture I like best on the website, whatever the case. And they never ask the rest of the question. What's the whole thing going to cost? And it's not until you layer in the facility piece that you get the whole picture. And that's when you're surprised, right? And the EOB comes and you're saying, wait a minute, I thought this was going to cost $400. Why is it $4,000? So unlike a lot of approaches, it's not about getting folks to switch their doctor. It's about using the doctor you know and trust, being real intentional about where they send your downstream care, tests, and procedures. And it's obviously not just colonoscopies. So this is work we do all across the country. Here's a basket of 10 very common outpatient procedures. And the outpatient procedures in general, we call the shop smart procedures, typically account for about 1/3 of most self-insured employers' total medical spend. And you have significant savings opportunity within that. So this is real data in the Las Vegas market. And you see the price variance on a number of those procedures, anywhere from 300 to over 1,200% variance in network, allowed amount from lowest cost to highest cost for the same procedure. And if you translate that to what it would cost if that was what was happening to gas, right, you would never pull into a gas station that had $16 a gallon gas. You wouldn't do it because the price is on the gas station, right? But it's not in the provider and the delivery system. So folks say, why is that? Why is a hospital 2, 3, 4, 10 times more for the same procedure as opposed to a non-hospital owned facility? Well, if you look at what's actually in the claims detail, this is what you find, right? So on the bottom, the $6,000 gallbladder removal, there's just a couple of lines: physician, anesthesia, facility. Hospital, same procedure, everything but the kitchen sink is in there. And it's not illegal, it's just the way they've grown up around how they can bill and what they do and spend money on in terms of revenue maximizing. We've heard about that today as well. But what's really kind of sad, and if you've got a good partner who's doing the claims analysis, you catch this stuff, is right about here. Can you see that? There's a urine pregnancy test, which would be fine, right, for anesthesia, except this was a male patient. So you've got to be cognizant of what happens when you step into the delivery system in the hospital world compared to an independent, non-hospital-owned facility. All right. You guys already know this, but I have to ask it. True or false? Higher price equals higher quality. Raise your hand if you think that's true. You guys all get A's, yeah. It's not. And the data is pretty strong about that. There is either no correlation or an inverse correlation between cost and quality. And if you look at it at a macro level, this is every state in the country, scatter plotted out. Horizontal axis is cost, vertical is quality. The highest cost state in the nation has the lowest quality. And you can see that many of the lower cost states have some of the highest quality. So it's true at a micro and at a macro level. All right, so what do you do about that then? What type of quality information does make sense? And we're having a great discussion over lunch with some folks around, as advisors to your clients, you've got to peel back what you hear about quality, because most of it doesn't actually pass muster. And for years, we did not have a good answer on inpatient quality. You've seen Leapfrog and others. There's nothing wrong with those information sources. The challenge is they'll give a hospital a single letter grade. Right? This one's an A, this one's a B, this one's a C. But most hospitals do most services, but they're not graded all services. So take Cleveland Clinic as an example. A lot of employers actually have travel programs to get their employees to Cleveland Clinic when they need cardiac care, because they're one of the best in the country at cardiac care. But if you look at them for joint replacement, they're in the bottom half of all hospitals in the country for joint replacement, but nobody knows that because Cleveland Clinic has the brand. So people assume if it's great at that, it's great at everything. You have to slice inpatient quality by the clinical category. You have to slice it by the clinical category. When you do, you've got something that's relevant to the patient. Because they don't care about how the hospital does on 40 other things. They care about how does the hospital do on my knee. This is what it looks like. In the Las Vegas market, we picked a clinical category, neurological surgery, and there are some excellent hospitals in the Las Vegas area for this procedure, right, indicated by the green, against all hospitals nationally. So if you drill into that, this is what it looks like. St. Rose is actually at the top of the heap, right? They're in the top decile for all hospitals across the country for neurological surgery. Pretty good. But keep this in mind, right? St. Rose, remember that name. So if we flip down and look at joint replacement, well, out of the gates, you've got a problem. There aren't any excellent hospitals in terms of quality outcomes on a longitudinal basis for joint replacement in Las Vegas. You can get lucky for sure, but when you look at the data, and this is pulling from MedPAR data across all hospitals in the country, there aren't any that are in the top quartile. But what's really interesting is, remember where St. Rose was? It was #1 for neurological care. It's in the bottom quartile for joint replacement. So a simple question like how good is that hospital is unfortunately a meaningless question. So our job is to take the same sort of complexity around this and translate it into, guess what, green, yellow, red, around quality outcomes. You can compare that and ultimately price and make some decisions. All right, so you figured out quality, you figured out cost, you still have this issue of how do my employees actually get in touch with this concept. So true or false? This one's not as easy. People are more discerning than birds. My wife has a distinct opinion about that when it comes to me, but I'll open it up. Any guesses? Hands up if you think people are more discerning than birds. No? Well, you familiar with this guy? Remember Conrad Lawrence? He was a scientist who did some imprinting studies, and he's more than just a crazy naked guy in a cold lake. So what he used to do was, as goslings hatched, right, he would wear these big yellow boots, and in the first critical period after they hatched, he'd walk around in these big yellow boots, and they'd follow him. And they followed him everywhere their entire lives, imprinting. Turns out, when it comes to things that we don't have familiarity with as humans, like healthcare pricing and healthcare shopping, we're about the same. So here's an example. If I told you, let's say you needed a gallbladder removal, and I said, well, hospital A is $15,000, hospital B, $17,000, hospital C is $20,000. You go, oh, okay, well, maybe the one in the middle. That becomes my reference point. It's not too high, not too low, it's like Goldilocks, right? But what if I told you, yeah, the fair price is actually $7,000? That changes your whole frame. But unless you have the right anchor point, you don't know how to compare anything because you've never shopped for a gallbladder before. Why would you, right? It's not like stuff you buy every day. So where you start determines where you finish. And for anyone who's focused on the wrong anchor point, right, which is just information about what hospitals charge, which is not the right anchor point. The right anchor point is what should an informed consumer pay in a given market, right? The right anchor point is not your out-of-pocket cost. Because if you're in a preventative service or if you've blown through your out-of-pocket, then it's of zero impact to you. And that's the wrong lens. The right lens for an employer aligning incentives with their employees is what's the true total cost of care. So there's a gentleman we worked with when we designed the site, Dr. Dan O'Reilly, a behavioral economist out of Duke. I don't know if any of you have heard of him, but this is a great book. I highly recommend it. Predictably Irrational. Not about healthcare. It's about how people make decisions with their money. He's one of the best in the world at understanding that. And not what people tell you they take into account when they make decisions with their money, but what they actually do. And it turns out the anchor point is key. People make decisions relative to something else, especially if you've never encountered that domain before, like shopping and healthcare. So the right anchor point, which in our view is what's the total fair price, is the point of comparison that people use from that point forward. He also informed us of some other things that are kind of interesting. For an example, an in-your-pocket incentive, right? A check in the mail for as small as $50 or $100 has a greater impact and sort of sentinel event for that employee or for that member and the people they talk to than a $2,000 out-of-pocket. It makes no sense. Financially, the $2,000 out-of-pocket is far more significant. But it's not real money to them in the same way that a check in the mail is. It becomes real as the bills mount up. But if you want to get someone's attention, an in-your-pocket incentive for an event they typically don't get paid for, like getting care, has a much bigger impact. So going back to simple wins and keeping things at a glance, simple, focused, intuitive. Now, compare this to what most health plan tools look like and a lot of other tools out there. This isn't to pick on anybody. The point is, I don't know what to do when I look at this. So you use the same litmus for any of your consumer-facing tools, right? Do I have a sense of where I should begin, or do I not? And if you in this room can't figure something out, there is zero chance that someone who's never shopped for care is going to actually dig in and stick with it. All right, another thing you hear quite a bit. It's intuitively appealing. A lot of folks think shopping for care should be like shopping on Amazon Prime, right? And God knows my family loves Amazon Prime. But it's not quite the same. So think about your own experience for a minute. I'll let that sink in. When you shop for a flat panel TV, it's kind of cool. You're excited about it. You want to read reviews. You want to compare features. You want to spend 30, 40 minutes figuring out which one am I going to get. When you need something, like a colonoscopy, you're not that psyched to really dig into the details. You just ideally wish you didn't need it at all, but now that you do, what's the simplest, easiest way to get the information I can need and get on with my life? So be thoughtful about that. You can't compare consumer experiences entirely. It's not the same frequency, it's not the same endpoint. Back to the simple wins concept. I'll show you this in the site, the Go Green to Get Green rewards program. So because of the partnership with Cypress, because we're getting the claims feed, so we know which employees are going where, when employers want to put this program in place, there's no additional cost to administer it. Here's the way it works. If my employer puts this in place, and I go to a green provider for any one of hundreds to thousands of procedures, like, say, a colonoscopy, I get a check in the mail. That's it. I don't have to fill out any forms. I don't have to track anything, because Bluebook is getting the claims feed, identifying who's going where in the delivery system, and on a bi-monthly basis, batching that information out, sending out the check and the letter to the employee explaining why they're getting it. And the speaker just before us described that people don't always trust what management tells them. They trust what their coworkers tell them. And the first time their coworker comes into the break room with a check for $50, and they probably saved $2,000, they talk about it. And people remember that. So think about this, especially if you maybe are at the limits of what you can do from a benefit plan perspective. There's a lot of trusts and other public entities that can't get quite as aggressive on the out-of-pocket. Even so, the in-your-pocket incentive has a significant sentinel effect. It's got to be mobile, not to overstate the obvious, but think about what actually happens, and I'll show you the way we address it on the online site as well. If you twist your knee and you go into the doc, and they say, yep, you're going to have to get an MRI. Well, you don't have your laptop with you, right? So what we see practically happen is the member says, hey, you know what, I'm paying the bill for this. Can you send me to any one of these green facilities? And the physician typically says, I don't see why not. Just talk to the front desk person on the way out and sign them up. We have yet to have a physician prevent a member from going to a green facility when they've actually had that conversation. Even physicians owned by hospitals. Because at the end of the day, I think they're confronted with the reality of making a decision that's better for them, convenience and otherwise, versus the patient that is paying this $2,000 bill out of pocket. So this is what the site looks like. I didn't try to do a live demo with internet because of you never know if the pipes are going to cooperate. But think about it in 3 very simple steps. What do I need, right? Not what does my doctor cost? Wrong question out of the gates. Not what is my out-of-pocket? That's the wrong question out of the gates. What do I need? What's the fair price? What's the price range and what's the fair price? Then where can I go to get it at a fair price? And then we can drill down into any of those facilities, get more information on the physicians, et cetera. The next question a patient asks, of their own mind typically, is what's in it for me, right? So the reward information, if you choose to do it, is plastered right above the provider list, and all of those green providers, you get the check as the member. The other thing we've started to do to try to get in front of that issue where a member gets sent to a red, high-cost provider for basic outpatient care because it's the habit of the physician office, it's more convenient for them, they didn't know there was a price difference, whatever the deal, is this we've started rolling out in a number of markets, starting with imaging. We've moved now into outpatient surgery and other procedures. is a book now function. It just creates a scheduling request packet so that if the member doesn't really want to have to call their physician back and try to argue and get a case moved, guess what? These green providers are more than happy to call the physician and get the case moved. They want the business just like a pharmacy will move your script. So it's a very simple but effective way to help prevent members getting caught in one of the teeth and the common traps of the delivery system where they're following a referral pattern that's convenient for the provider but maybe not in the best interest of the patient. So where does all this kind of end up? Here's an example. Again, got some formatting stuff, but one of our early self-insured employers, where it says 201 is actually 2011. That's the pre-period. So all of that utilization, those claims are for, in this case, an MRI, before they began using the Bluebook, a one-year snapshot. And what you see is that most of the care, just like most of the folks who gambled last night, most of the care was going to the red higher cost providers. 1 year later, above the dotted line, 2012, different picture. Much greater utilization of the green providers. Average cost of care dropped for just that one type of procedure by $1,000 per image. And we go procedure by procedure to look at the impact, claims-based, case by case, all the way out. But in just this MRI example, this employer saved about 24 grand with a reward cost of about $600. And the good news is, over time, we see that pattern increase and continue. Sort of the drumbeat starts to take effect and people realize that where they go matters and that when they go green, they end up paying less and getting more. And we see an increase in the utilization of green providers over time for employers that do this for more than a year. How are we doing on time? So one other thing I wanted to show you, kind of the bonus round, is last year we also dove into specialty pharma. It's a big problem, as you guys know, and particularly the high-cost injectables that are occurring in the medical claims side, not on the pharma side. We routinely see cost differences from $2,500 to $30,000 for the exact same monthly dose, right? Only determinant that's driving that difference is where the patient's receiving it. Home infusion physician office, maybe 3 grand. Hospital, 30 grand. Same exact dose, same frequency, same everything. But because this is sitting in the medical claims side, it doesn't always see the light of day. So we focus on some of the highest cost, highest variability offenders, and this is client data. Each one of these orange dots is a claim, in this case, for Neulasta. And you can see that there's a number of them clustered well up above $15,000, where the fair price administered in a physician's office closer to $5,000. So the frequency, obviously, of folks that are on specialty pharma, high-cost injectables like this, is not that common, but the cost when it happens is huge. So we've incorporated this into our solution as well. We have it as an online listing, if you will, but we do this as a site of care intervention with a PharmD calling the member that we identify through the claims run to let them know their options. Employers can also pair rewards with this because typically if it's a member who's on a high-cost injectable, they're through their out-of-pocket in the first month of the year. So that's kind of the flyby, and I think, as you decide how you're going to best advise your partners or if, as an employer, what makes the most sense for you going forward, think about what actually works, right? Start with what matters and moves the needle. It's not about doctor shopping, it's not about office visits, it's about the bigger ticket items, right? Got to keep it simple where folks can get in and out of the tool quickly and make it available to them in whatever form they need. So in addition to online and mobile, we have a phone support and intervention service because we work with trucking companies and others where no one's going to be online and no one's going to be checking their smartphone. So think about practically what works for your culture and your employees. And ultimately choose something that you can integrate with whatever other programs you're already spending money on. Think about transparency, not about a tool or as a solution, as it's sort of the insight into what's really going on in the network, no matter what network you're in. So anytime any of your employees have a question about care or about to get directed for care, you want this information between your current vendor and the employee, right? So the classic thing we see is we work with wellness companies as well, and they'll send out a letter, right, a campaign for folks who are turning 50 and need a colonoscopy. So they're actually generating demand for care, which is all good, it's indicated. But by using the Bluebook, we can API in a simple sentence that says, and here are 4 high-quality, low-cost providers within 5 miles of your home. That one little sentence, right, changes the entire trajectory of where that program goes and where people seek care. Because if without that, what happens is They go to the doc, and the delivery system has its own inertia. Three quarters or more of your employees will end up at the higher cost locations for that simple colonoscopy. So think about that as you move forward. When you line it up that way, focusing on what works, keeping it simple, tying it into your other programs, you can predictably end up at something that's going to generate real savings for you and your employees and their family members. Thank you.
All right.